This is Dr. David Pomeroy, your host on ADHD Focus. I wanted to remind you that the show is not intended to be a recommendation for diagnosis or treatment of any condition for any specific person. Please consult your mental health professional or doctor managing your ADHD or mental health issues about any diagnosis or treatment-related information that you hear on the show. Refer your ADHD provider to the show if he or she would like more information. We're here today to talk again with Dr. Bill Dodson, who is one of the leaders in thought and practice in ADHD. He has over 20 years experience in the field of adult ADHD. And Bill, welcome back to the program.
Pleasure to be here, Dad.
So today we're going to be talking about rejection sensitivity, which is an extreme example of the emotional dysregulation. So what have you found?
The special case of rejection-sensitive dysphoria was discovered 50 years ago by Paul Winder, and then for a whole bunch of reasons got intentionally ignored. And it then got rediscovered 5 or 6 years ago. And right now, it's brand new. But we're just doing the very first studies now on validating the concept that, yeah, it really is a thing. And here's the research to back it up, because there isn't any right now. So that's coming.
Mm-hmm. And Bill, I'm going to compliment you on your modesty, but I remember hearing you talk in a ADD conference. Boy, it must have been
10 years ago.
10 years ago, and you said you and your group have tried to sort out this, why do people with ADD so reactive when they perceive being rejected, ignored, discounted, and that rejection sensitivity. So you and folks you've worked with or talked with are really the pioneers, I think, in identifying this.
Yeah, in fact, that conference was the first time we presented our stuff in public. Mm-hmm. And it was very well received. People who have ADHD really identify with it. So that, again, this is one of those separations where people who have ADHD have a totally different understanding of what's going on than the people who research ADHD.
Mm-hmm.
They really are almost totally separate existences. One of the things that you and I were talking about was that for people who have ADHD, the term hyperfocus is coined around. Everybody knows what it is. Everybody's had it. Everybody understands the term. But if you do a search in the literature, there's not a single mention of the concept. Anywhere, anytime, any language. It's just not there. So there's a great disconnect between the people who experience and live ADHD and those who research and write about it.
And I think since doing research, you have to be really organized, plan in advance, keep track of a lot of details. Probably most of the researchers don't have ADHD.
That's right. Most of the people who treat ADHD do have ADHD. And that's how they got into it. Either they had a terrible time getting their ADHD treated, or they have a friend or family member who got terrible treatment for their ADHD, and that's what gave them the motivation to say, I'm going to spend 1,000 hours of my time learning how to do this well.
Yeah.
Just about everybody I know is pretty much self-taught, because there's no other place to learn it. So again, that's one of the great disconnects. So the reason that rejection-sensitive dysphoria got sort of put to the wayside is it's very difficult to research. One, it's not always there.
Yes.
Two, when it is there, you can't measure it. Now, how do you measure dysphoria, feeling bad, or where there's no measure? And the third reason is most people who have rejection sensitivity are very ashamed of it. They feel very guilty about it. They don't want anybody to know about it. So they're not going to tell you unless you know to ask. So those three strikes mean it's almost impossible to really research it, validate it, measure it, and most of all, publish. So many people, if I can't publish it, I'm not going to bother with it. So the definition, the question that's on my checklist, actually comes out of an old psychiatric textbook as the definition of rejection-sensitive dysphoria. And it goes, for your entire life, have you always been much more sensitive than other people you know to rejection, teasing, criticism, or your own perception that you failed or fallen short? In my practice, like 98% of people would check that. They put stars by it. They underline it. My personal favorite was, this caused my first 3 divorces. ADHD it's an epiphany. You mean I'm not alone in this? Other people feel it? And so it's a very powerful emotional experience. In fact, the term dysphoria is Greek for unbearable. Nobody likes being criticized. Nobody likes being rejected. But for people with ADHD, it's a totally different critter. It's
that exaggerated, disproportionate feeling where someone else would say, hey, I was just teasing. And that person doesn't understand. That was huge. I think of one little guy here when we were talking about symptoms and things, and Mom said, yes, when you do that. And he said, well, you're yelling at me. And I'm thinking, no, Mom's tone of voice changes the third time she asks you, but the volume doesn't go up. To the child, you're yelling at me. You're really piling on this I'm really bad kind of thing. That or different perceptions.
Michael Jelinek article about the fact that by the 12th birthday, the average child with ADHD has heard 20,000 additional negative or corrective messages, whether they are on medication or not. You just can't have 20,000 negative messages without it having an impact on anybody.
Yeah.
There's a reality here. But that's something you really have to explain to non-ADHD people, is this is more than what you experience. It's a lot more. People with ADHD, basically they kept on telling the researchers, I can hardly stand it. And again, at Harvard, they had to put it in Greek. They wanted to put it how devastating this emotional experience was right up there in the name, and then they put it in Greek. And you got to love those.
Dysphoria,
Dysphoria.
Yeah.
So it's an intense emotional experience that most people with ADHD spend their lives trying to protect themselves from it. They become people pleasers. They spend their lives scanning everybody in their world, figuring out what it is that person would approve of or praise, and that's what they give them. Oftentimes, for people with ADHD, they are so busy making sure that everybody else is happy that they lose track of what they wanted for their lives.
Oh, boy.
They're so busy with other people's desires.
And I see that time and time again where someone will, as we're talking, finally say, yeah, well, I want to make sure everybody else is okay, or, well, I'm helping others, and I'm thinking, yes, but you're not helping yourself. and you're really stifling yourself and not going out and doing some things you need, and people wear out. There's a limit of how much you can do that, and so that's a toll this takes on people with ADHD.
Oh, absolutely. And I see it with 45-year-old mothers. The kids are now grown. They're off at college, and it's her turn. Now it's my turn, and nobody's there to help her.
Yes.
And talk about resentment of, I spent 45 years of my life doing this, and now there's no appreciation. Whoa, that's other people try to be perfectionists, to be above reproach, above criticism. Some people just give up trying. These are the slackers of the world, the people with ADHD who are brilliant. They've got a college degree, but they do nothing with their lives. And it's because the whole notion, the imagination of going out there, trying something in front of everybody and failing, terrifying. And so it's better not to try at all. I've got lots of patients who have never been able to apply for a job, who have never been able to ask somebody out on a date, because just the imagination of being turned down is so devastating, it's better to not even try. So the rejection sensitivity literally takes their lives away, because they'd rather avoid the pain and not have a life than risk that devastating emotional pain.
Yeah, and I'm reminded when you say avoid the pain, which yes, most people would say, yeah, I want to avoid pain. And I think it's the opening line of M. Scott Peck's book, The Road Less Traveled. Life is about how you deal with your pain. Pain's going to be there. That's part of life. How are you going to deal with it?
That's the whole principle of Zen Buddhism. Life is suffering.
So what can people do about this? How can you, and I know medication is one thing we've talked about. Right. Of the things you can do, medication is one. Are there others?
The answer is we don't know. It's what my patients tell me. That's the best I can do. Is that this hits so quickly. Again, it goes from 0 to devastating in a fraction of a second. That there's no time to use dialectical behavioral therapy. The techniques might work for all we know, but not fast enough. And it's a perception, and the episode goes from 0 to full in a second. And what I hear from my patients is, once it gets started, it has to run its course. Because I just, when I'm in it, I just feel totally devastated, powerless to do anything about it. I just all of my energy goes into trying to look like to other people that nothing's going on.
Right, and I explain it to people as there's the emotional reactivity pathway in your brain, and then there's another pathway that takes emotions or situations through the thinking part, the prefrontal cortex, the executive functions. When this hits, there's nothing going down the thinking pathway. Right. And when one is in the middle of it, you can't make it do that. And so I have seen parents or spouses say, well, I'm just trying to reason with them. You can't reason with someone when they're in the middle of that. And I think that's universal. If
somebody's drowning, you can't reason with them.
Right. So you do have to step back and just let it happen. And my experience is that people with ADD, once they've calmed down, they're they're mortified that they've done this, and they apologize, and they're feeling a lot of remorse, but they don't know how to change it the next time. Which is, meanwhile, the person that's just been, hit with both barrels is thinking, boy, I don't want that to happen again. And yes, thanks for apologizing, but I'm really scared.
Right. The other thing that I hear from my patients is that, again, when they are in the midst of one of these episodes, they feel profoundly cut off from other people. They describe a profound loneliness, as if I've been cast out, as if I'm outside the realm of other people, isolated, and disconnected from the world around them. It is as if their participation in their environment just grinds to a halt until this episode has run its course. So it's very hard for other people to reach them. The few people who have found something that works will say if they can find something new, fascinating to get engaged with, that can pull them out very quick. Again, but it's very hard to have the presence of mind to do that.
Yeah.
And also I've had several people say that somebody who uses some very gentle humor can help bring them out. It's a gentle, what they call a gentle invitation to return to an accepting, non-judgmental relationship. Many people, that's very helpful, but the other person has to know that.
Yes, so there's an awareness and an education part. Bill, I want to redirect us a little bit to the medication side, not because certainly that's the only solution, but we're running up into time here. And I do want people to know that, yes, medication can help. It's not the answer, just as stimulants don't answer everything in ADHD. So what have you found the most effective medication? And
the most effective one is difficult to use, and that are the monoamine oxidase inhibitors, which require that you have to go on a diet, you have to avoid medications, the most important of which are the ADHD stimulants. So the MAOIs are very difficult to use, but they're extremely effective for about 85% of people. And when they work, people just love them. They're willing to put up with all of this hassle. The easier ones to use, and when they work exceedingly well, are again the alpha-2 agonist. Guanfacine, clonidine, the response rate, the very robust, life-changing response rate to each one is fairly low, disappointingly low, at about 30%. So if you took 100 people, started them on whichever alpha agonist you were feeling lucky with that day, about 30% of people, it's going to change their lives. 70% of people are going to go, what's the big woo? I don't see anything, or it's drowsy. In that case, if that happens, you stop that one and you try the other one, and there's another 30% chance they're going to respond. It's a 30% response rate, but it's a different 30% of the patient population.
Yeah.
So that in total, if you end up having to try both, you get about a 55 to 60% life-changing level of response, and usually with no side effects.
Once you kind of get used to it, or kind of it goes away, like the jitteriness of an ADD medicine, a stimulant. When someone starts it, that usually wears off. It may take longer, say, for the drowsiness to wear off.
Tolerant in a matter of days. There are 4 common side effects. The big one is whenever you're adjusting the adrenaline system downward, you're going to run the risk of some mild sedation. In all years of practice, I've had only one person who was not able to get up and go to work, get up and go to school. I mean, they feel sedated, but they still function. Next most common is dry mouth. Next most common is a mild headache that again goes away in about 3 days. And then the last one is an accentuation of a universal experience. Everybody's had it of when we stand up suddenly and get a little dizzy, vision goes a little gray. The technical term is orthostasis. That can become more frequent, but usually you also have to be fluid depleted, dehydrated for that to happen as well. So if that happens, drink another liter of water, you'll be fine.
And that's the commonly known head rush.
Head rush.
You stand up and you get that kind of rushed feeling. I'm going to need to cut short our discussion, which we probably could keep on going for another 2 hours anyway. But this has been very, very helpful in looking at the emotional dysregulation, that oversensitivity to emotions, which I liken to the sensitivity to texture of clothes or to noise. Well, there's a sensitivity of emotions. And then the very special, or special, it's certainly not special if you're in the middle of it, but distinctive, yes, case of the rejection sensitivity, which is, I guess, an extreme example of the emotional dysregulation. And I think this has been very helpful information to me, and I'm sure to my listeners. This is Dr. David Pomeroy, your host of ADHD Focus, and I thank my guest, Dr. Bill Dodson, for his expertise in the field and sharing that with us. So with that, Bill, thank you so much for another opportunity to talk with you.
Well, thanks for inviting me, David. I appreciate it.
Okay. Take care.